Thursday speaker series. I'm Richard Kravitz. I'm UCCS director. Today's topic is homelessness, and specifically veterans homelessness. California is actually the home to 1.9 million veterans, which is the greatest number of any state in the union. And as all of us know, just from taking a walk around the Capitol, we also have a significant homeless problem in many of the cities within our state. And in many ways, these problems overlap. And I think we're going to hear about that overlap and some potential solutions from today's speaker, who is Kenneth W. Kizer. Dr. Kizer is Distinguished Professor of Emergency Medicine and Nursing at the UC Davis School of Medicine and the Betty Irene Moore School of Nursing. He's also director of the Institute for Health Policy Improvement. Among his many prior positions, he was Undersecretary of Health in the Veterans Administration in the 1990s under Bill Clinton, where he's widely credited with performing a complete overhaul of the VA healthcare system and dramatically improving the quality of care that was delivered by that system. And people still refer to that as a model of how a bureaucracy, if you will, can reform itself. He's also served in many positions in both academia and in government. He happened to have been director of the California Department of Health Services prior to his service in Washington, and also director of emergency medical services. His bachelor's degree is from Stanford. He received his medical degree from UCLA and also a master's of public health. He's board certified in 6 medical specialties, so practically no matter what your medical complaint is, you can ask Dr. Kizer. He'll have an answer for you. He's published numerous papers, monographs, book chapters. He's the winner of too many awards really to recount, but they include the Gustav Lienhard Medal from the Institute of Medicine, which is a highly prestigious award in health policy, perhaps the most prestigious. So we're very pleased to welcome Dr. Kizer today to talk on California's veterans homeless problem.
Okay. Whoa. Now it's really on. Can we turn it down? Okay, now let me see if I can make this technology work too. So you heard that first part. A couple of other points at the outset is that the Veterans Housing and Homelessness Prevention Program is very much a work in progress. It's still relatively early. No evaluation has been done on it yet. So there's more to come, and what I will share with you at this point are really preliminary results of the first couple rounds of funding. I would say that the people who are actually doing all the work on this are 3 state agencies: the Department of Housing and Community Development, the California Department of Veterans Affairs, and the California Health Financing Authority. They were gracious enough to let me share some of their data. I see some of the people here, which means that I will probably be calling on them at some point to answer the questions, which I suspect I inevitably may not be able to answer. So with that as kind of opening filler, what I would like to do in the time that I have with you is basically four things. As I said, I want to introduce the Institute for Population Health Improvement. I'll provide a relatively high-level overview of the Veterans Housing and Homelessness Prevention Act and Proposition 41. We typically connote them the same, but they were two separate actions, as I'll mention. I wanted to describe some of what is known about homelessness among veterans, both nationally and here in California. And then I'd like to end with some of the lessons, perhaps, that have been learned in addressing homelessness among veterans broadly that may be applicable to dealing with homelessness in the general population. I would note that I currently chair the National Academy of Medicine's Committee on Housing, Health, and Homelessness. We're doing a very deep dive into permanent supportive housing. We are literally finalizing our draft report this week, and it will be out in a few months. It undergoes a rigorous review process and some other stuff before it gets out, but hopefully it'll be out sometime in the summer time frame. And unfortunately, I can't talk about what's in it per the Academy rules, which they enforce vigorously. We really can't talk about what it says until it's undergone peer review and all the other things that happen before a National Academy report gets published. So with that, let me move forward to say a little bit about the the Institute for Population Health Improvement, which has been around now a little more than 5 years. And the history behind this is basically I was at UC Davis as a department chair a long time ago, and then that after I was Director of Health for California through most of the 1980s and did a few other things, was in UC Davis, then went back and joined the Clinton administration and spent some additional years in Washington and did other things. And then I came back to academia in 2011 to establish the Institute with one of the things that always had impressed me in my time in government was that there is a potential very synergistic relationship between academia and government that has not been realized or operationalized very well anywhere, and particularly here in California between the UC system and the various state health agencies, which is the turf I'm most familiar with. There actually are some better examples in agricultural and some of the other areas, but it hasn't happened much in health. Generally, the things that the state works with academia on are kind of one-off, opportunistic, episodic things, and it's never been viewed as how do we have a strategic relationship where we bring the assets and the resources of a university, and certainly a university with all the assets that the University of California does, to partner with the state in a way that there's actually synergies and some sort of strategic advantages. So that was kind of the mindset or the idea behind the Institute. In the years that it has been around now, a little over 5 years, we've focused our efforts in 5 broad categories: quality improvement and data analytics and trying to generate health intelligence. The last time I was in this room, we were talking about some of the work that we'd done on Medi-Cal superutilizers. And it was the first time that data had actually ever been presented broadly. There was tremendous interest in it. Indeed, we couldn't accommodate everybody here, and there was subsequently a webinar where more than 500 people participated. But that's just one small example of how bringing the analytic abilities, not that the state doesn't have very good analytic abilities, but there are some potentialities to enhance that. We focused on health leadership development, work with the Sierra Health Foundation and the Milbank Memorial Fund, both on a regional and national leadership development programs. We do some health policy and some public health practice stuff. Most of all of our work has been with various state agencies. And secondarily with philanthropies. We, unlike most centers or institutes, we have very few actual dedicated research grants, and while we do a lot of investigative stuff, it's not the traditional research type things that most centers and institutes within academia do. That's probably more than you want to know about it, but I thought it would I'm going to tell a little bit of some of the programs that we're doing just to flesh this out. We've been relatively successful in generating work and have accrued more than 110 million in funded projects to date. Some of the ones that I'd highlight on this on the next slide, we work with Medi-Cal and the Department of Healthcare Services, particularly in trying to improve the quality of services that are provided there. We do the day-to-day management or operations of the California Cancer Registry, one of the largest population-based cancer registries in the world. Ironically, I established it in 1988, and I was in a different capacity. It's kind of come full circle. We managed the California Health Equality Program when that was in operation as a federally funded program to develop health information exchange. We worked with a number of the public health programs providing technical and other support. We completed a statewide assessment of surgical adverse events. And yes, they happen at most hospitals in the state, but we'll save that for another conversation. And we do some other things, for example, new models of care. We did a feasibility study on community paramedicine, which is the idea that paramedics probably could do a lot more than they currently do. They have the training to do that, but by law they cannot. We did a feasibility study. The state is now doing 12 different pilot projects to develop some on-the-ground experience there with the idea that maybe we can operationalize this more broadly in the future. Currently work with the Department of Managed Healthcare on some quality improvement efforts. We work with other departments in that regard. And you can read through this. We do some obesity prevention stuff. I probably don't pay as much attention to that as I should. And we, among other things, we have provided some support to the Department of Housing and Community Development with regard to the Veterans Housing and Homelessness Prevention Program, which is what we are now going to turn to and focus on here. If anyone should be interested in this, there was a book chapter that was just published that describes the Institute and what we've been doing in much more detail. So let's talk about the VHHP. The program had its origins back in 2013 when then Speaker Perez passed legislation to restructure the Veterans Bond Act, which had been passed in 2008, and it had provided $900 million in funding to support housing for veterans. As you may recall, a bunch of things happened in the 2008, 2009, 10 timeframe. The funds were not being utilized as much as had been expected, so the program was restructured to try to support affordable multifamily supportive housing for veterans. $600 million in general obligation bonds was targeted for that purpose if approved by the voters. So the legislation was passed in 2013. The measure, Prop 41, was put on the ballot, and it was overwhelmingly approved by voters in June of 2014, and it has since been implemented. The lead agency is the Housing and Community Development, but they work very closely with CalVet and with the California Housing Finance Authority. I should digress and talk a little bit about the veteran population in California. As Rich noted in his introductory comments, California has the largest number of veterans of any state, 1.9 million. These data, by the way, come from the 2015 census data. One of the things you find when you read the literature in this regard, there are lots of numbers and they aren't all the same. So I want to tie what I say to a specific source, because you will see if you look in the literature some different numbers. These ostensibly are the most recent and the perhaps the best data that we have. Texas and Florida and New York are the other three states that have large numbers of veterans, not surprising based on their populations. Now, in contrast, as a percent of the population, veterans only make up slightly more than 6% of the population. We're the third lowest, 48th of the 50 states, as far as veterans' proportion of the population. Perhaps not surprisingly, while the veterans are found throughout the state, they are disproportionately concentrated in Southern California and the San Francisco Bay Area, Los Angeles, Orange County, in Empire, San Bernardino, Riverside counties, and San Diego have some of the largest veteran populations or local veteran populations in the state. Overwhelmingly male, consistent with the historically veterans have been male-centric, or the services have. That is changing. The number of women in the military now is up around 20%, close to that. So correspondingly, the number of female veterans is also increasing. The Vietnam-era veterans are the largest single cohort, but they come from World War II and Korea and the recent conflicts in Southwest Asia and elsewhere. Overall, veterans have a lower unemployment rate than the general population. This number is perhaps not accurate insofar as employment is a bit better today, but at least at this point in time, about 7% of the veteran population was unemployed. There are about 250,000 veterans who receive monthly disability compensation from the U.S. Department of Veterans Affairs. And on any given night, somewhere around 11,000 to 12,000 veterans are homeless. Again, the Census Bureau put it at around 12,000 at this point in time. It's a little bit less than that now. When we talk about homeless veterans, historically and still today, veterans are disproportionately represented among persons who are experiencing homelessness. Again, the specific numbers and percents change or vary, but they are overly represented in the overall homeless population. And there's a variety of reasons from that, some of which relate to military service, some of which may relate to where the individuals came from and what their life was like before the military. And again, it's a complex etiology for that. Overwhelmingly male, as you'd expect, overwhelmingly single, disproportionately African American nationally. Mostly this is an urban situation. More than 70% reside in major cities. And in excess of 50% have some sort of mental or behavioral health problem and or a physical disability. And again, many of these are quite complex syndromes or combinations of mental substance use and physical disabilities. The number of who have a substance use problem is over 70% in most of the studies, 75%, and in combination often with other things. And the majority tend to be over 50. I was going to say tend to be older, but 50 actually looks pretty young these days. But it's, you know, they are on that end of the age spectrum. If you look at the distribution of veterans who are experiencing homelessness nationally, and I took this from the Interagency Council on Homelessness, and it's a little dated as 2013, but the pattern remains the same. California, Texas, Florida, New York lead with the largest numbers of homeless veterans. And California has about a quarter, a little more than a quarter of all of the homeless veterans in the country. Again, within California, the veterans are disproportionately represented among the population of persons who are experiencing homelessness. Since 5 or 6, 7 years ago, when there's been a much concerted effort to decrease homelessness among veterans, actually California has lagged behind somewhat, not grossly, but somewhat lagged behind the decreases that have been seen nationally, although I think that situation is improving. As I mentioned before, on any given night, at least in recent years, somewhere around 11 to 12,000 veterans will be homeless. These assessments are done in a point-in-time assessment. Again, one of the reasons why you'll see differences is that assessments are done on a certain day, and on a different day that number might be slightly different. But that's how these assessments are done, and that's what at least we're seeing in recent years. Again, disproportionately single males, but a significantly growing numbers of women and families. This idea of homeless families is something that, if you look historically, just didn't get much attention, but it's an increasing part of the homeless population that needs to be addressed. Not surprisingly, as elsewhere, they're mostly urban in our major cities, and in California mostly concentrated in Southern California and the counties that I already mentioned. And again, they have pretty much the same spectrum that the majority have some sort of mental, behavioral health, physical disability, complicating their lack of stable housing. And again, you can, this is another slide I borrowed from the Interagency Council, and you can see how the numbers have decreased nationally in blue, and California has not dropped quite as rapidly, at least up to 2013. There may be some improvement there more recently. So going back to the VHHP program specifically, the funds are awarded through a competitive application process, something called the NOFA, it's the Notice of Funding Availability. It's a process certainly has been used by Housing and Community Development, but lots of other agencies, kind of the same generic government means of offering funds. The legislation requires a number of things among the programs that are funded by or with these funds to leverage other sources of funding, whether they're public or private community programs, to try to maximize the return on investment by bundling or mixing funding streams. Although that's often problematic because different programs have different restrictions on how the funds can be used, and but that's a topic perhaps for another conversation. To prioritize projects that provide supportive services along with housing. And again, if you look at the demographics and the epidemiology of homeless veterans, more than half have mental, substance use, other problems. So appropriately, housing is not enough often. They need other supportive services, which may be employment training, or it may be case management, or clinical services of various types, substance use help, etc. It's the law intends that to promote and drive public-private partnerships. They want to foster innovative financing opportunities, and want to prioritize programs that have demonstrated experience in providing the supportive services along with the housing, and who have knowledge and experience treating veterans. Veterans have unique issues. They have other things, some of which we'll just mention briefly in a moment. And the law is intended to try to address those unique and special needs that veterans have that may not be prevalent or present in non-veteran homeless groups. The measure does not provide funding to individuals, nor does it fund services per se. This is for the housing part of it. Also, the one other way that it's different than nationally is that this measure takes a very inclusive view of veterans and provides support and housing for those who have a less than honorable discharge. And there are a couple of different categories of folks who have dishonorable or bad conduct or general discharges, and the federal programs typically don't provide services if you have less than honorable discharge. California, the intent is to provide support and help house anyone who has worn the uniform. Just a little bit, as I said at the outset, we're still early on. We're just barely at midterm and implementation of the measure. There have been the expectation was that this would be, or the money would be allocated over a 5-year period, and that each year there would be, or essentially each year there would be a new NOFA, a new allocation of funding. 2 of those rounds of funding have been completed for a total of $179 million allocated as of June of last year. The 3rd NOFA is currently underway. More than 1,500 housing units have been supported by this, the majority of which provide supportive housing, and a good number which are dedicated for the chronic homeless, which are typically the ones who also need the most in the way of supportive services. And more than 2,000 veterans have been housed. 85% of the funds so far have gone to the areas in Southern California that we mentioned before: LA, Orange County, Inland Empire, San Diego, and a significant chunk to the San Francisco Bay Area, and then others spread out elsewhere. If you want a little bit more granular detail, and this just comes from the Housing and Community Development website, you can see how much has been funded in the 2 NOFAs. About 30%, a little more than 30% of the funds have been allocated to date. I don't know that for purposes of this conversation we need to delve too deeply into these numbers. I would just note that there has been a considerable success in leveraging and combining funding streams, which is the intent of the law. It's providing housing for those extremely low income veterans who have more than 50% of their income goes to housing. And again, you can see the specific numbers. The program is not yet achieving its target, but it certainly has made good progress, and with 3 more rounds of funding to be allocated. So we'll see where the numbers go over the next few years. And again, not to belabor this, but most of the money is going to the areas that were already noted. So the program, any program of this magnitude is going to have some challenges, not the least of which is just getting up and running. $600 million of money that you want to move out the door as quickly as possible, but you want to do it in a fiscally prudent and sound manner that's going to stand up to all the scrutiny and the oversight that's going to come. So they're just the program startup challenges that are inherent to this. Also, it's really a 3-agency effort. Trust me, I've been there, and when you try to get more than one agency, it's usually hard enough to get one agency moving in the same direction. But to get 3 moving in the same direction and to address all the issues, there are inherent problems in that regard. I think those have been dealt with quite well. Another issue that continues to be something of focus is ensuring that the housing providers have the requisite competency to deal with veterans and who are knowledgeable about the unique needs of veterans. But it's not just their unique needs, but what are the services and the benefits that are available? Veterans are eligible for a lot of benefits and services that non-veterans are not eligible for. Education, home loan support, there's a number of things. And the providers need to be aware of that as part of the services that they're providing. Again, dealing with the mental, behavioral health, physical disabilities of the population creates issues and challenges as well. And particularly among the veteran population and those from the recent conflicts in Southwest Asia, but certainly in the Vietnam cohort as well, the PTSD issues. As you know, that's the signature injury, the signature problem of the conflicts in Iraq and Afghanistan. And associated with that is the traumatic brain injury. And these two are commingled in a very large number of people, and it's often hard to sort out what's the TBI, what's the PTSD, and what may be other issues as well. Challenges related to funding the projects for women veterans and families. A large number of the female homeless individuals have a history of military sexual abuse, military sexual trauma, which creates a certain need for an environment that is cognizant and addresses those issues when you house them. The family issue, these are increasing needs. And then citing projects in rural locations. While the population of homeless veterans is skewed towards the large urban areas, there are veterans throughout California, and there are certainly veterans in rural areas. And we often see among the veterans in rural areas a higher prevalence of PTSD, substance abuse, other issues, because life can be less complicated there. So being able to have the critical mass to provide the development and the housing providers in these rural areas continues to be a challenge. I want to shift gears a little bit and talk about the U.S. Department of Veterans Affairs and its role in providing services for persons experiencing homelessness. To the surprise of many, VA is actually the largest provider of hands-on services for homeless persons in the nation. And it is, in essence, the fifth mission of the certainly the Veterans Health Administration, which provides health care for veterans. It provides postgraduate education for 47 different types of healthcare professionals. About 120,000 trainees rotate through the VA every year, and many people find it surprising that the largest provider of health professional training in the U.S. is the Department of Veterans Affairs. It is a very large research organization, has about a $2 billion a year research budget, both intramurally, a dedicated program of about $550 million, and then the VA is very successful. VA investigators are very successful in competing for NIH and other sources of funding, so it's a very large, very productive research program. And then again, one of the less known, well-known missions of the VA and the Veterans Health Administration particularly is its role in providing contingency support for national emergencies and disasters. It's the only national healthcare system in the U.S. And while sometimes people think of, for example, the CDC as managing the pharmaceutical stockpiles for national disasters, you might be hard-pressed to find where's the pharmacy at the CDC. And often those things are done with subcontract with other entities, not the least which VA, which manages all those things like atropine and other chemicals on a daily basis. And so it's a logical, sensible thing to do. But the fifth mission there is providing services for homelessness. The first four are statutorily mandated. The fifth is just as a function of the population that VA tends to serve. The Secretary of Veterans Affairs, Eric Shinseki, at least in 2010, and President Obama decided to make a commitment or had discussions in 2009, 2010, made a commitment in 2010 to eliminate homelessness among veterans by 2015. And then they went about fashioning a plan, dedicating resources, working with other entities at the federal, state, and local levels, designing programs specifically to do this. And while they have not achieved that goal, there has been dramatic reductions among veterans or veteran homeless persons over the last 5 years. It's dropped nearly 50%. And one of the reasons why I highlight this is they made a conscious and dedicated commitment, put in place a plan, dedicated resources to execute it, and what you see are dramatic improvements. And there is a lesson there that certainly is applicable more broadly. The number of homeless veterans now is less than 40,000 a night. That's still a really large number, but that's dramatically less than what it was a decade ago. As I mentioned at the outset, California has been a little not in the vanguard of some of these. This was an article from the LA Times where LA and the facilities and VA facilities in Los Angeles have put together a plan, and they're working with the Department of Health Services and other community organizations in LA to make some more rapid progress there. The 101, just as a trivia point of no particular significance, but there's 101 VA facilities in California. And many billions of dollars of healthcare funds are spent by the VA in California each year. One of the things I found surprising, and I'm totally digressing here, but in the 7 years that I was Director of Health for California, I never once heard from a VA. I just found that astounding when I went to the organization, that they have such a large footprint and presence here, and yet they have, at least at that time, no interaction with the rest of the healthcare community. Now, things have changed, and I think they'll continue to change in the future, but I continue to find that astounding that that sort of thing would happen. So let me just wrap this up with perhaps some of the lessons that have been learned in addressing homelessness among veterans that may be more broadly applicable. I think the first, and maybe this is stating the obvious, but persons experience homelessness, and especially those who are chronically homeless, face a lot of life challenges, and it's complex. And it's important to recognize, because those who would say, well, we just need to do this and we will fix the problem, don't really have any grasp of how complex and difficult the problem is. There is no single solution that will solve the homelessness problem. The solutions, we need multiple different solutions that need to be tailored to the groups that we're targeting. And much of that is going to require provision of supportive services. You know, providing housing is a necessary condition to dealing with this, but it's not sufficient. And again, that's something that many people haven't really internalized. That yet, it's really hard to take care of many of the chronic health conditions that these individuals have. You know, consider trying to take care of someone who's just had chemotherapy when they're out here on the K Street Mall, or if you're diabetic, which refrigerator do you use to put your insulin in when you don't have a house? Or if you have HIV/AIDS and you on this complicated medication regimen, where do you store your meds? Where do you get your meds? Where do you deal with all this side effects and other things? So it's very hard to take care of people who have chronic health problems in the absence of stable housing, but providing housing is just the beginning. We have to then provide other supportive services that are tailored to their particular needs and circumstances. I think one of the clear lessons that comes out of the VA experience is that if a clear commitment is made, accompanied by a plan, a good plan, and the resources to go with it, material progress can be made, and it can be made in relatively short periods of time. And I think that's a lesson that certainly needs to be understood broadly, but it requires that commitment, not only on paper and in word, but also with resources to follow, and the sort of innovative and creative programs that are needed to deal with sometimes local or particular circumstances. Again, I think one of the lessons that come out of the experience with dealing with homelessness among veterans is the power of partnerships between different levels of government, federal, state, local, between government and the private sector, both the for-profit and the non-for-profit, the philanthropic, the community-based organizations, and many of those have to be tailored and designed to deal with local circumstances and who the local players are. But this is not a problem that one entity is likely to be able to address or solve. It really requires many people helping out and playing different roles. The other thing that is clear from looking at this is that we need more precise data about who needs what types of supportive services and in what combination and when do they need them and how do they need them. And when you read the literature in this regard, people talk about supportive services as opposed to usual care, but they tend never to describe what are those supportive services, nor do they describe what usual care is. So you're kind of left, okay, it worked, but what was done and you know, who did it and how was it done? And the literature is replete with examples of imprecision where we really need much more precise data. If we're going to tailor the types of programs that are needed to address a problem, you really need to know what it was or what it is that's going to benefit a given audience. The last thing I thought I would leave you with was an article that was put forth last fall, but then there was another one just this week about the rate of rise of housing prices in Sacramento. I just wanted to end bringing this on a local note. Housing prices in Sacramento went up 11% between 2015 and 2016. They're still 11%, the highest in the nation. The mayor has made a commitment to try to address homelessness in the Sacramento area. Housing prices are zooming up. There is a housing shortage for people who can't afford it. So it's just, if this is going to be addressed locally, there are some particular challenges. I mean, in many ways, this is good. The economy here is doing well. There's a lot of jobs. People are coming here because there are jobs. Housing prices are rising because of that. But as far as dealing with homelessness, it creates some particular challenges that are going to be difficult to deal with. The supply of affordable housing locally is declining precipitously just because property values are going up. So with that, let me stop. I would be happy to try to take questions or answer those or not answer them if that's the right thing to do. Teresa Gunn is here from Calvet. I don't see anyone from Department of, oh, okay. So I want to actually give them the opportunity to, if there's anything they want to add or say, take a moment and then we'll turn to questions.